our pathologists, because it is such a rare disease and requires such extraordinary expertise. Leslie Litsky, for one, gets slides from all over the world to help make this diagnosis from other institutions. So Leslie is going to be speaking to us about just that.
Good morning. Let me tell you what a privilege it is to be here. I'm a pathologist. I'm a doctor who you almost never get to meet. And you, the patients and the family, the most important people in my professional life, are people who I rarely get to meet. So I'm thrilled to be here, to be able to personally answer your questions, and I'm looking forward to that. I think we're going to have a competition to decide who has the hardest task in 10 minutes to explain to you about making the diagnosis of malignant mesothelioma. I do know some of you are very educated in this audience, and I may be telling you something that perhaps you didn't understand at the time, but now you'll understand a lot better. Okay, so besides talking about making the diagnosis of malignant mesothelioma, which one? This one? Okay. I think I have to explain what is a pathologist. And if you don't know, don't feel badly. I would say at least once a week, both in professional circles and in social circles, I have to explain to somebody what I do. Exactly. Right, and I have to deal with the fact that, no, I don't do that part-time. All right, so as a broad group, pathologists do a lot of things. We're involved in patient care. Many of us are involved in research, in education, medical students, residents, fellows, and also we're often the medical directors of laboratories. Then, within pathologists, there are anatomic pathologists. Anatomic pathologists are a very specialized group of people who diagnose disease by looking at different types of materials, cells, and you may have cells, for example, many have had pleural fluid removed, looking at cells in pleural fluid, looking at cells, Dan mentioned when you do e-buses, pulling out cells, little pieces of tissue, sometimes bigger pieces of tissue, pieces of pleura, lung, and sometimes at autopsy. We do what's called gross examination, and everybody thinks that's sort of gross, but what that really means is looking at it in its entirety. Microscopic examination, we look at a lot of slides. And also, we do a lot of specialized techniques, including immunohistochemistry, which I will get to in a little bit. Right. But if all that's a little bit for you to get your head around, you can just say what my daughters say. Mommy looks at lots of slides under the microscope all day long. Now I did it worse. Okay. So, why is a pathology diagnosis important? Well, the first reason is a lot of symptoms that people have are not specific. Chest pain can be a lot of different types of things. Shortness of breath can be a lot of different types of things. There's radiology. We have outstanding thoracic radiologists, but sometimes they can only go so far. They can tell you that there's a mass in the chest, but they may not be able to tell you what kind of mass it is. But treatment decisions are certainly based on definitive pathologic classification. There may be some prognostic information that comes with a more specific subclassification of the pathologic process. And as we all know, it's an unfortunate truth, but compensation claims are certainly, it's important to have a definitive diagnosis to pursue that. It's important to know that lots of tumors can involve the pleura. It's a dubious distinction, but of course mesothelioma is a relatively rare tumor. And for all comers, people who come with tumors in the chest, one of the most common things for that to be is actually lung cancer that's metastatic to the pleura. So one of my main jobs is, first of all, sorting out a far more common disease from a rare one. There are also lots of metastatic tumors that involve the chest and the lung, and that actually is also far more common. So people who've had a previous history of another type of malignancy, it's important for me to be able to sort that out. And then when we get to the rare of the rare, primary tumors, primary pleural tumors, there is malignant mesothelioma, but there are other tumors, a lot of them rare, which will involve the pleura. So it is often the case, as Joe mentioned before, that these slides are re-reviewed by someone who's an expert in thoracic pathology. And it's also often the case that we need to do what people sort of say, additional studies. And mostly that comes down to immunohistochemistry. And everybody doesn't like immunohistochemistry because it usually delays the diagnosis. This takes several days to perform, to examine the tissue, to cut the tissue, and to do the stains. And everybody's kind of sitting on tetherhooks while we're doing those studies. All right, this is even harder. What is immunohistochemistry? Well, as you all know, probably the best place to just figure out things these days is just to Google it. And so I said, well, this will probably be the easiest way. And sure enough, even Wikipedia has a definition of immunohistochemistry. And this is the Wikipedia definition. I abridged some of it. So immunohistochemistry, or immunohistochemical stains, or IHC, or some people just like to call them brown stains, you can see why, refers to a process which takes advantage of the fact that cells, tumor cells, other cells, have antigens, in other words, proteins on their surface, and they have somewhat unique proteins on the surface depending on the tumor, and you can get commercially available antibodies to see if those antibodies bind to the antigen. And if there's a positive reaction, you get a positive visualization like you see here. So you see here on the left a positive brown stain. Dan already showed you an example of that in another setting, and a negative one on the right. This is used all the time, not just in malignant mesothelioma, but in the diagnosis of a lot of different types of tumors. Why are we talking about immunohistochemistry? Well, malignant mesothelioma is one of the tumors which it is absolutely integral to the diagnosis of the tumor to have immunohistochemistry. There are many, many discussions about what is an appropriate panel, and I'll get into that in a little bit. But basically, it's not just one immunostain. It's usually at least two affirmative, meaning positive. We expect it to be positive mesothelioma, and two negative. We expect it to be negative in mesothelioma, and that's very important. And the other caveat to that is that education and experience in using immunohistochemistry in general, and education and experience in interpreting immunohistochemistry in general is very important, and particular for malignant mesothelioma. So here we have two tumors. They really look pretty much alike, and I can tell you that any pathologist sitting there would not be able to tell you which one of those is malignant mesothelioma. And honestly, actually, I have to go back and look to see which one is malignant mesothelioma. So it illustrates the problem. And many tumors are what we call relatively undifferentiated. They look malignant, they're clearly malignant, but we don't exactly know where they came from. Well, fortunately, there are guidelines. And if you want to talk about sort of breaking news, if you go into PubMed, you'll see this. It's not even, I think, available as a full article yet. But there is what we call a consensus group. There's an international mesothelioma interest group, of which we're all members, people coming together from all over the world to discuss this relatively rare tumor. And there is, in fact, a pathology subgroup. And actually, this goes back to 2008, 2009. We were asked by the organization, they locked us all up in a room and they said, you pathologists, you experts, this is such a mess, you come up with what you think are the best practice guidelines for the diagnosis of malignant mesothelioma. And it covers a lot of these different issues that you see before you. And in particular, because immunohistochemistry is so complicated and so controversial, it focuses on how you should go about making that diagnosis and what types of immunohistochemical stains are probably the hardiest, the best to use, although leaving some leeway for variations in practice. And so if you really want to get into it and really want to read up into it, this is probably the single best article to read on the pathologic diagnosis of malignant mesothelioma. So finally, I just want to summarize just those sort of big take-home points. As a patient, you should expect a definitive diagnosis of malignant mesothelioma, and that should be confirmed by immunohistochemistry. And perhaps in retrospect, or perhaps prospectively, this may explain why you may have had to undergo a number of procedures. So there's lots of doctor-doctor communication that goes on behind the scenes. I get to play the bad guy, where I say, I think I need a little bit more tissue. And then they groan, and then they go back, and then it's their job to, as safely as possible, get more tissue. And why do I need more tissue? One is I think you're best served by a definitive diagnosis of malignant mesothelioma. Two, and I think this is the most exciting thing, already in lung cancer we're seeing how important even small biopsies are for doing molecular studies. We're really hoping in the not-too-distant future that the molecular analysis of the tumor tissue is going to be important. And if we don't have the tumor tissue, we're not going to be able to do those kinds of molecular studies. So not just for your diagnosis now, but going forward, I think this is going to be extremely important. So if they come back and say, we need to do this, we need to do that, maybe we'll do this again, I think that's the reason why. And the second thing is, I don't want to delve into this, it's a sort of specialization thing, but there is what we call subtyping of malignant mesothelioma into the sort of three broad major categories of epithelioid or epithelial, biphasic, and sarcomatoid. And you should expect, if there's enough material, that the pathologist subclassifies that, because there's a lot of prognostic information that may be conveyed within that as well. And as I said before, at the end of the session, I'll be happy to take any questions.
Well, I've known Leslie 15 years, and I finally know what she does. So that was no. I'm just kidding. I got to tell you, without Leslie, without world-class pathology, you're flying blind. You have absolutely no idea what you're doing, and I can't stress how critical it is to our program to have Leslie here and have this expertise available. That is what allows us to help you decide what are the appropriate options.